Uh, Good evening, ladies and gentlemen. We first have to apologize, we are far behind time, but of course, we are the human we are, and we all know we needed to give it a little time, believing others will join us for us to start the whole program. Whatever it is, we're going ahead, and we hope with time the rest will make it to this place, and then we have a full hall, hopefully. As usual, being the Ghanaians or Africans we are, prayer is virtually part of us, and we have in our midst, I call him Alhaji anyway, Alhaji Yusuf Uro, who is going to lead us in a very short prayer, and then we start with the program. So if we can stay seated and bow our heads, Alhaji will lead us in prayers.
In the name of Allah, the gracious, the merciful, we are gathered here before our sister Linda Boateng and our brothers Dr. Charles Ajiman and Dr. Michael Arthur, who have gone so far in their quest for knowledge, and today they are ready to share it with us. May Allah guide them, bless them bountifully, and grant them His wisdom. And for we also who are here to learn from them, may Allah grant us the listening ears and the ability to digest and ingest what they are going to teach us today and send it back to our various communities. May Allah guide us all and protect us. Bismillahir Rahmanir Rahim. Alhamdulillahi Rabbil Alameen. Ar-Rahmanir Rahim. Maliki Yawmiddin. Iyaka na'budu wa iyaka nasta'in. Ihdina siratal mustaqim. Siratal ladzina an'amta alayhim. غير المغضوب عليهم ولا الضالين. Amen.
Amen. Now, to the presence of God invoked, I think the appropriate thing now is to invite our speakers for this evening to take their seats, and then we start formally with the session. For those of you who have had the benefit of looking at the program, we have three speakers this evening. The first on the list is Miss. We have to stay that way for now, because that's her professional name, Miss Linda Boateng. She is a researcher in public health. She had a stint with the Guy study, and the follow-up to the High study was the Helios. She also participated in that. And this evening we have her in our midst. She is going to share some information on that with us. After that, we have also Dr. Charles Ajiman, who was a lead partner in the Helios study as well. He is assistant professor at the AMC. We also have, at the very last moment on the program, we've had Mr. Justice Lai from Anansi Pharmacy, who was going to take us through the subject of self-medication. The last moment he had to travel out to the UK, and fortunately we got our brother, a very young doctor, who is also practicing with the AMC, and he is going to take the place of Mr. Justice Lai to share with us, his thoughts on self-medication. And the name is Dr. Michael Arthur. Belinda, could you please take your seat here, and then Charles, please join her, and with all respect, Dr. Arthur. This is beautiful. I mean, they are our kind, in God's name. And here's the situation we've been talking about, issue of health. We all know from the studies, it is really a situation that we need to talk about. I don't mind whether we have one person, 2, 3 here. Of course, whatever we say here is being recorded for television. Those who, for whatever reason, are not able to be here, we take the information to them in the comfort of their home. So we don't have to worry, but I hope by the time we finish, the seats will be filled up. Having said that, and if I am not to preempt whatever information they have for us, we will invite Ms. Linda Boatin to take us through her presentation, please. Thank you very much. Can you see the nice one as well? Okay.
Hello everyone. Welcome once again to this important day, this important evening. I'm here to present to you a study we conducted not too long ago about people's views about the healthcare, how Ghanaians are able to access the Dutch healthcare system in which we live. An outline of my presentation will entail the background of the Gaia study, the plans and methods we use, the findings, that's the results, and an opportunity for a discussion later on. Well, Ghanaians, I think we've heard it's on different platforms, are the largest sub-Saharan African group in the Netherlands. Currently around 20,000 or more, according to the CBS. And we know that migration also comes with many health challenges. There are some indications of common diseases. However, we really do not know so much. The health of Ghanaians, data about them is really rare. Thankfully, we have an opportunity to do this Gaia study. Gaia is Ghanaians in Amsterdam, simple as that. And we were able to ask people's views about how they are able to access the health system. Yes, please. So our aim was to explore the issues in access to healthcare and also to elucidate some common diseases among Ghanaians in Amsterdam. Like I said, we didn't really know. We've only heard of some indications from previous studies by Dr. John, but on a last sample, we didn't know that much. And also, we wanted to kind of help to provide advice that fits with Ghanaians' way of life. It is our way of life, it's our culture, but how do we help Ghanaians? Okay. So the method we use, we had 2 phases. We had phase 1 where we did the focus group discussions, and then phase 2 where most people were invited for a physical examination and also to answer a questionnaire. The phase 1 is what I'm going to present to you this evening. We had 6 focus groups. A total number of 51 people participated, and these are the age ranges of the people who participated. We have kind of more youth, 18 to 30-year-olds were more in the group we sampled, and as at the time we were doing the research, we had fewer elderly people, that those above 60, but it went quite well. We work with theories sometimes in our research, and the theory we use in this particular study is called the theory of healthcare utilization. It maps up population factors, that's things that is about us, we can't really change, that's our age, our gender, ethnicity, and determinants. Determinants are those things that determine, of course, how we are able to access health. That includes our need for healthcare, the enabling resources, the barriers, what prevents us from accessing healthcare, and our predisposing factors such as our culture. And then these are depending on each other in anyone's life in the way they utilize healthcare, and that is the healthcare system. So first we asked, it was a very lovely discussions, I should say. In all of the 6 groups we had, we asked people their need for healthcare. Why? What is your need in accessing care? And the main issues that came up are perceived health or ill health condition. That is, if people feel they are healthy or they are not healthy, that is what makes them, that's their need to access health. And these are quotes I'm going to present to you literally. That's how they said it during the discussions. A man of 41 years old said, yes, it's true that high blood pressure can affect both the young and the old. Secondly, and I think another common disease that affects some Ghanaians is stroke. So he was mentioning some diseases he knows is among the community. So that is what would make people go and seek care. Then health priority. One lady of 35 years said, to me, a healthy person is one without any ailments. A person without any ill condition in all aspects of health, whether mentally, physically, or whatever. Health priority, being healthy, is what drives people to seek care. Okay. So what enables you to seek care? Knowledge. People were able to identify what they know about the Dutch healthcare system. One man of 55 years said, I think the system is informative, which is quite true. The delivery of information is usually through the press, radio, and television, which I think is good. So for this reason alone, this man thinks it's an enabling resource for him to seek care. He's confident about that knowledge. Then the benefits they get from the care, from the health care we live with. The day I came to, we omit the name of the hospital. The day I came to this hospital, the theater was very clean. He was very happy with it. I said to myself that here, I know that I am not going to die. Because in Ghana, when you are going to the theater, everyone is like, hey, he's going to die. This is a usual quote. I think most of us will be familiar with it. The fact that the hospital is clean is enough for him. It is his benefit. It's an enabling resource for him. Okay, can we go on, please? So what are the barriers in what stops people, or what is kind of a constraint in accessing healthcare? Language. Language was a dominant issue in all of the groups we sampled. Everybody wanted to talk about language. One woman said, most of us Ghanaians cannot speak Netherlands. And of course, our English is not so good. It is difficult for us to express ourselves to our doctors. So language is a problem. The fact that she mentions English indicates that the doctors, some doctors, are willing to listen to us in English. But even with that, it's a problem. So would the doctors speak Twi or Ga or Hausa, or what do we want the Dutch doctors to speak with us? It's a problem, language. Trust in the doctor or the system. We have issues with the way the doctors do things with us. We really are not happy about it. One man said, they behave as if, that is the doctors, they behave as if the drug they are prescribing, they are going to test it on you. You can get the feeling that he, the doctor, is trying you like an experiment, so that he is not really sure, he cannot trust what the doctor is doing with him. He sits in front of the doctor, but the doctor's prescription, he feels it, he said, that it sounds like he's trying him like an experiment. That is barrier. Another issue with barrier in accessing care among Ghanaians was expectations. We have already made up our mind about the way the doctor should treat us. So if it doesn't go that way, it's a big deal. One woman said, a very young woman actually, she said, she was counting her incidents, when I went to my house doctor with pain in my breast and chest area, I was expecting her to at least come over and examine me. Instead, she used the stethoscope to check my heartbeat and then said, everything is all right. So that's all what the doctor said. Probably she was expecting something else. I'm sure you all know. When we break into the workshop, I would like to hear your views. So this is a familiar quote. Then another man said, well, we asked them about the time they spend with their GPs. He said, the longest time I have ever had with my house doctor is 5 minutes. 5 minutes. That's the longest time the doctor wants to spend with you. So what would you do with 5 minutes? By the time you finish saying your story, 5 minutes is over, the doctor doesn't have enough time for you. Okay. So what predisposes? Our culture and the way we acculturate ourselves when we migrate is a big deal for us. Here in this country, one woman said, we talk about everything. That is the way the Dutch talk. They talk about everything. The Dutch way of doing things. They talk about everything from A to Z. But we, Ghanaians, have hyphens and clauses. I would like to know what these hyphens and clauses are. Because if you are able to translate exactly what that word is to the doctor, I'm sure he will treat you. But if your culture says you cannot say breast, you cannot say this, then of course it's a problem. Okay. So when we put all these issues into the theory we used, this is what happens. Our age, our gender, ethnicity is surely depending on the determinants. Perceived health, for instance, the knowledge of the healthcare system, the benefit we get, the language, which is a problem, trust in doctor is a problem, expectations for treatment is a problem, and of course, what this predisposes us, our culture and the way we acculturate. And this translates into the way we utilize healthcare. So conclusions. So perceptions of diseases and quality of the healthcare system are the main drivers in seeking healthcare. These are what drives people. And language and trust in doctor are barriers. These are just a few of the barriers. I would like to hear from you what other barriers you think are. So we recommended that a further study is needed to elucidate the extent of these perceptions. We did not know how far these perceptions affect people on hand, whether there are problems, so that it could foster effective interventions or planned treatment. So we were fortunate enough to be included as Ghanaians in the Helios study we've all heard, and I'm sure Dr. Jamai would tell you some things about Helios. Helios is an acronym for Healthy Life in an Urban Setting, and Ghanaians, among other groups like the Surinamese, Moroccans, Turkish, and the Dutch, were included in this study. It's an initiative of, a joint initiative of AMC and KKD, and the main focus were on cardiovascular diseases, infectious diseases, and mental health. So this is the end of my presentation. Looking forward to the workshop to listen to your views about what we found in the Gaia study, if you have any other. Thank you very much for having me.
Thank you very much, Linda. I think the quick thing to do is to have Dr. Ajma come on to give us further information. We're going to switch over to his presentation, and then he takes it up. So thank you very much, Dr. Ajma.
Thank you very much.
The floor is yours.
Thank you. Linda has managed to give us an overview of what is really happening, what are people thinking about their health. So what I'm going to try to do now is to give us a gist of what the extent of the problem and the need for people to actually seek help. To do so, I'm going to go through this. I might go up a couple of minutes up, but forgive me because I have to add one or two things. First, I will talk a little bit about the health of the migrant or minority population, which Ghanaians are one of them. And then I'll talk a little bit about the health status of the Ghanaian population in Amsterdam, based on some of the work that we've been doing. And then I'll try and talk a bit more also about the potential factors underneath that. And then furthermore, you can discuss a little bit more, what can we do to improve the situation? So that's going to be my talk. Well, when you start, you look at the health of the minority populations. We know that Linda already said that in many countries, minority population actually a huge number. In Amsterdam, for example, if you put all those people that were not born here, it's about nearly 35%. That is a huge number. And we know that when you look at the chronic diseases, they tend to be much more affected compared to the white Dutch population. We also see a huge differences between the migrants themselves. And the typical example is heart disease and stroke, which is more common when you talk about the Indian or the South Asian population. But then when you look at the African population, we know that stroke is a huge burden, but for some reason heart diseases tend to be quite low. Why is this? We don't know. We also know that when you then look at the risk factors, it also tends to be quite consistent with the risk factors. You know, for instance, that when you talk about hypertension, everybody knows that it's a huge problem in Ghanaian community and also the other African populations. We tend to call it pressure. When you move on and then you talk about diabetes, you also know that, of course, it is also a problem among the African population, but it's a much, much bigger problem among the Indian population. Why is that? Yes. What about the Ghanaian population? And Linda's already mentioned that it's one of the biggest groups in Amsterdam. There are a tremendous amount of many health challenges within the Ghanaian populations. We talk a little bit about obesity, which is a huge burden. I'll be showing you some of the figures to do that. Blood pressure is also a major issue. And so is diabetes. Diabetes rate that we are seeing is actually quite scary. Many of the Ghanaian population now are no more younger anymore. We are all getting old. That also means that the problem is going to continue unless we do something about it. And of course, we've all heard about the media that the Ghanaian population in Amsterdam is among the poorest. And you also know that the poverty and health are intrinsically linked. And a typical example is that if you are poor, you'll be able to buy a healthy food to eat in the first place. You'll be able to basically eat properly at home, and so the cycle continues. And then also affect you, your health. It also affect you the way you'll be able to seek a proper job. So it is very closely linked. Next, please. So what is the figures? We talked a little bit about the Gaia, but now we have a much bigger study here, that's Linda. So this is the work actually I'm about to submit an application. So I decided to give you some of the figures. And I've put some arrows to show us what is happening. This is a hypertension. We all know pressure. And this is the population within the Amsterdam. And you see here, this is the Ghanaian here, this is African Sudanese, this is the South Asian, that is the Hindustani, and you have the Turkish, Moroccan, and the Dutch population. And these figures actually show if you have 100 people, how many of them have actually hypertension. And this is the Ghanaian population sitting here. If you move the arrows up, this is the Dutch and this is the Moroccan population. So you see that we are very much disadvantaged. I know that some of us don't want to talk about that the Ghanaians are sick or you are ill. But it's the only way you can make a difference. You can only make a difference when you make it, people know that there's a problem here, you have to solve it. And it's not only the Ghanaian, but also for the Dutch population. When there is a problem, we have to pick it up and then do something about it. So if you assume that you don't want some people to hear about our problems, you'll be deceiving ourselves. And then if you then, please if you go back, please. If you then sort of move it up to different ages, those among 50 to 70, nearly about 80% do have hypertension. So it's a huge problem within the community. Please, next slide. You also know that, not that the people don't know they have the problem. I mean, the Ghanaian people know very well that they have the problem. Yeah? So if you see people who know that they do have the hypertension, again here, this is about 60 compared to almost everybody else. Those are receiving treatment. People are also receiving treatment. Before, the work we did, we were quite concerned that people are not being treated because of poor language, because of access. But they're actually more likely to be receiving the medication compared to the Dutch people. But for some reason, when it comes in terms of control, look at where the Ghanaian population are sitting compared to the Dutch people. What is going on? So that seems to me that here, we cannot blame people for not giving us the medication, but it might well be that we are doing something here, either we are not taking our medication, or the medication is not working for us. But of course, it needs to be found, further up. But also what I want to say is that before, actually the numbers have gone up. The work that I did about 2006, only about 14% of the Ghanaians on hypertension were controlled. So we're a little bit up, but still, we are really far behind. Women are doing much better, but still, we are also less likely than the white population to do so. Next slide. So why is it important that we control hypertension? Well, it's absolutely crucial that we control it, because if you don't, it can affect all the organs in your body. And that includes your brain. And when you lose that, that's actually what causes stroke. If you go back, please. And if you don't take care, especially the stroke, it can basically end your life. If you die, you are lucky. But if you don't die, and then you have it in a very, very bad form, it can affect the entire family behind you. It can affect your blood vessel, it can affect your heart, the kidney also an issue. So that's why it's so, so important that once someone got a pressure, it needs to be handled. Next slide, please. And I put in this quotation because I think it's about 1929. Many of us were not born. There was a work done then, and I like to quote this when I'm giving my talk because to show you how things are. And this guy did some work in Kenya, and he wrote, I think almost everybody who has been closely, if you go back please, associated with the African native would agree that that he very rarely can be ascribed as living, as living a high pressure existence. That's basically what they mean, is that in those days, not only blood pressure was low, it did actually not increase with age. So what is happening? Something is happening. Next slide, please. It's not only on hypertension, but it's also diabetes as well. Diabetes used to be low, but now you're beginning to see a huge increases. This one also is among Ghanaian population. I'm not scaring people, but I'm just telling you what is happening. And that also means that we need to do something. This is diabetes. This is a men, Ghanaian men. Nearly about 15%. If you compare to the Dutchmen, it's just only 5%. And even the African Surinamese, which are also African population, they are here. So it can only be due to just being a black. It means like something else is happening. The same thing actually, if we then use what you call the African American Diabetic Association guideline. So diabetes is also an issue. Next slide. And this has to do with obesity. Obesity is a big thing within our communities. Of course, before you used to think that if you are big, you are healthy, you are, sort of good living. It's a good living. But unfortunately, it's not true. It's not good for us. And if you look at this, is the work that we did it in our a couple of years ago. This is those of Ghanaians living in the rural Ghana. This is what I did, I think, a while ago. And this is those living in the urban centers, which is Kumasi. And this is the age, which is just about 40 and 40 and above. And this is those living in Amsterdam. So, and if you go to women, it's actually the opposite. So this actually also tells us that we are doing something. It has to do with the diet, it has to do with something else, which is actually putting us at the higher risk of obesity and then related risk factors. Because you cannot argue, or you cannot tell me that if someone is living in Ghana and having this, and we are having this here, something is going on. Next slide, please. So then the question then becomes, why is it that, such an issue? Why is it that the Ghanaians are at higher risk of these chronic diseases? It's a very tricky question, actually. Why is it that? Of course, you know that there are some factors, business, that play a role, but we need more information to be able to help us. But what the risk factor we know, though, is that tobacco use. But I can say that one of the things that the Ghanaian stands out across the world is smoking. Smoking is the, Ghanaians are among the people with the lowest rate of smoking in all over the world. So that is a bonus. And even within the Netherlands as well, actually it's just about 2%. So that is a very, very good plus. Physical inactivity is also another issue, but that's naturally it is. If you are in Ghana, you walk. When you are here, people, even when the shop is nearby, they just want to sit in their car. An unhealthy diet is also a big, big issue. Sometimes we tend that we are eating the traditional diet, but the way you prepare it, probably, especially the chipo and others. So these are things that actually put us at a higher risk. And of course, the harmful use of alcohol. I mean, alcohol is also not an issue. There is also an issue of poverty. I mean, poverty is a big issue among our community. I mean, it's quite sad sometimes when you say, and I'll talk about it, we are also getting old. And of course, the genetic predisposition is also an issue that needs to be studied. And psychosocial stress. The stress, everybody will tell you, the stress from home, when you don't have it, they think you have it. And sometimes too, our also response to that give opportunity for them to even bother as much. If you don't have it, you pretend you do have it. And sometimes when you go to Ghana, you sit in a Mercedes Benz. So people, so if you go to Ghana, you sit in a Mercedes Benz, and then they phone you and just say that give me money to pay for the fees, and you say you don't. If I was there, I would be hungry. So probably you have to cut our coat according to our size. Next, please. So what can you do about it? Well, many of them actually just link to what I've said before. Healthy nutrition is a very, very important. The diet aspect part is absolutely crucial, the way we eat. I think it's one of the things that changes a lot when you migrate or when you move to another country. What about the physical activity? Sometimes you take it for granted. But physical activity is so, so important, not only for cardiovascular disease, also for cancers and everything. So it's very, very important that we move. It's absolutely crucial. And stop smoking. And also, some of us who have ended up on a medication, it is absolutely important that you don't play with your medication. We know very well some of the work that you've done, that especially for men, people deliberately don't want to take the medication because they know that it's going to affect their sexual performance. If you have a concern about it, talk to your doctor. They can always change it for a different medication. So that's not a justification to lose it, because if you don't, you lose both. You will just die. And of course, if you do have a concern, please just discuss it with your doctor. They are there to serve you. They are servants. You just ask them, sorry, I'm having a problem with this. Can you please change it? It's just a matter of communication. And please avoid unnecessary stress. Let's try and cut our coat according to sizes. If you don't have it, say, sorry, I don't have it. And when let's go to Ghana, just be normal. And the diet is absolutely crucial. Why? Because some of these food that you actually eat is quite incredible. This is Kalai, one of my PhD students sent me here to demonstrate to you. This is the Coke that you just only take it as a granted. Look at the sugars in this just one kind of Coke. So if you have this, and some people drink about 2 times of this, just look at what you're drinking for the whole day. So some of these food have a huge, huge impact on our health. Next, please. Not only those that, even those that they market it as very healthy, it's actually, some of them are not healthy. You saw that if you drink orange juice, and you have to be careful. Look at what this orange juice, look at what the sugar is containing. So you really, really have to be conscious about what we eat. Next. So, yeah, we are what we eat. So basically, if you don't eat well, that means that you should expect that our body will react. So then you need to basically, the portion size is very, very important. Sometimes you go there and the food is there, and you just have to watch what you eat. And that's called it the mindless eating. You have to be very, very conscious. Next. So, what can we do about it? I will look at it and we talk about the individual level. The societal level, what can we do? Well, the city council, for instance, or Amsterdam can do a lot to help. we just Ghanaian community needs to come together and put their agenda on the table. You need to take the political aspect part and then really come in as a unified force. And that, if you do that, you can really make a difference. And the community organizations are also doing, can do a lot. And a typical example is that part of where we are now. I think Doris is doing a very good job. And we need a lot of them. You know, what they are doing, for instance, healthcare, those that need care, especially the people in our community, sometimes people get old, they don't even have friends. You know, so if you to come to a place like that where you can interact with others, that can help. They also provide something like home care, youth care, and so many things. So I think this is a very good model that we need to build on. You know, something like that could help. What about the scientific level, like some of us who have been very busy doing for many years? I think you also have a role to play. And I think that is so crucial that we take this very seriously. Because if you don't, what we then do is that we go to hospital, we just give you what is used, because we know that some of the medication actually don't work best. So we need a lot of research into that. Some people think that when you're doing research, you are just using them as guinea pigs. But isn't. You just need to basically get more information to help us to understand why. For instance, why is it that hypertension is a big problem among the Ghanaian community? So that also means that sometimes you have to sacrifice and come in and then get into the study. And then when the results comes in and it's not on our favor, you should be ready to accept it and then work towards it and solve the problem. And sometimes, people get annoyed with me that why do you even publish that Ghanaians have a problem of hypertension? What? If you don't do it, nobody will look at it. Look even at the control rate. Now many people are aware, beginning to go up a little bit. So when it's a bad news, we need to put our feet down and just work out how can we improve the situation rather than pretending that it's not an issue. And then of a very good example is just because of time, just go through it. Next slide, please. There has been a lot of initiative, and now myself has been leading what you call a very big project. We talk about the Healer study. The Healer study is just one part within the Amsterdam. But now we are also trying to help us to see why is it that some of us, such as the Ghanaian population, are so susceptible to some of the health outcomes that we see. So in doing so, next slide, please. A few people on So in doing so, we are trying to now look at the Ghanaian population, next please, who live in the rural and then urban Ghana, and those that have moved to, yes please, Netherlands, and then England, and then Germany, if you stop there. And then, that's okay. So basically, we want to see if you live in one specific part of Europe, would your risk be higher than if you are living in another part? And how is your risk compared to those living in the rural and urban Ghana? And does it mean that, can it help us to identify specific patterns that can help us to basically understand why some of us are more susceptible? So this project is a huge project. It's keeping me awake for many years now. And this is our Ghana team. This is our car that they use to go to rural Ghana villages and then collect the data over there. And these are the young clinicians who are very busy collecting the data in Ghana. Next slide, please. And in London too, I'm working together with the London School of Hygiene and Tropical Medicine. And they are also collecting data in London, a large database. And the next, please. And in Germany, we're working with Charité, and they're also collecting data among the Ghanaian population. And of course, in Amsterdam too, we're also collecting data. And we hope that this kind of information can really help us to understand what is going on. And the information that we use as well can help back home in Ghana, so it becomes a win-win situation. Yeah. And this is basically our website, basically for the study. So those that want to basically see what is happening, luckily I just published the methods, and we've managed to finish the data collection now. We've got about 6,000 individuals now. So now there's a few PhD students from Ghana and here working on it. So we hope that in the next coming of years, we can contribute tremendously about seeing what is happening and then use that as a very important step to help us to understand. So that's my message. Thank you very much.
Thank you very much, Charles. I think when he got to where he called, what can we do? There was mention of expected support from the district council. And I need mention that the district council is already playing a role. This session, for instance, is fully sponsored by the STASDA. So this I need to acknowledge here, first and foremost. I think he also mentioned participation, especially when it comes to research. Efforts, we need to wholeheartedly participate. He mentioned something about guinea pig, as experiments. Now, I think some of us in the community, time it was where you hear people discuss the AMC, and it's like you dare not go there, because you go there and don't expect to come out, still the human you are. And there was this rumor that, look, they will do experiment, with your body. Now, the complaint is about students dealing with you, as a patient. And my quick answer to those who did come up with those complaints is that the doctor today was yesterday a medical student. So of course, without the students being given the opportunity to get trained actually to be the doctor, we are not likely to have enough, when we are sick, to tend to us. Now, we need to actually, as a community, come to terms with the fact that the community has grown tremendously from years back. When some of us came here, I came here in 94, it was still not big, but now we have a whole number of us around, and we're growing, older and not younger. So of course, these ailments here and there are likely to pop up. And there can't be any better way of helping ourselves than be present at sessions like this. I'm sure the issues being discussed here, if you are here, whether or not you have the opportunity to see it on the telly, you would also benefit, physically, to ask questions that will be addressed. There's no way you can ask the television question anymore. But if you are present here, whatever issue you have, you can bring it forward and it can be addressed. Now, I think there's also this element of privacy. People tend to be unnecessarily too private about their health, and that is doing a lot of harm to us, and it's not helping the doctors to also actually do the job they need to be able to solve some of these problems. Before Dr. Arthur will join us, I think originally when we set the concept up, it was to discuss the issue of the results of the CHI, the Helios, and then we look at the self-medication issue. But we have in our midst here Mr. Ray Achiampo. Now, for those of us who've been listening very much to the radio, I think last, was it Wednesday, I heard him talk about a center, a diagnostic center, Ray Ben, diagnostics that has been newly set up in Kumasi in Ghana. Now, for what you need to know, what they are trying to do is to carry the standard from here to Ghana. I won't take the words from his mouth. We're going to give him a little chance after Dr. Arthur is finished to tell us a little bit about what they are doing there. Because the situation we have in is some of us who are used to standards here, you never can tell when sickness will come. You could be home, something happens. And just as Linda said, when you walk into the hospital, the environment is enough to tell you whether you walk out healed or you should forget about coming back to the comfort of your home. So that's what Ben is trying to do. So he will give us a very small, information on what they are doing. So at this stage, I think I'll give the opportunity to Dr. Michael Atta to
Thank you for this opportunity. Actually, I'm not a pharmacist, I'm a medical practitioner, I'm a surgeon. But I'm going to talk about drugs, and that is dangers of self-medication and drug abuse. But I will be linking it with the medical side. When you talk about self-medication and drug abuse, it's a very huge topic. But I would like to tackle paracetamol, aspirin, and there's something that we call antihypertensive. It's something like antihypertensive drug. And I will talk about diabetic drugs, and also I will talk about enema. I don't know how to put it in G. Enema, I don't know how to put it in G.
Enema is,
they will apply through their...
what is it?
I don't know how to put it in.
You see, they used to have
Yeah.
yeah, something like that.
Yeah.
Something like that.
Yeah. The reason why I want to talk about it is our Ghanaians. We like paracetamol. If someone is going through a very mild headache, the person will just take paracetamol or aspirin, or aspirin is very good. Even we did a research that when you are above 40 years or 45 years, try to take aspirin every day, the low doses every day once. It prevents stroke. But one thing is, we have two types of stroke. We have ischemic stroke, that is situation whereby your heart, your brain will not be able to receive enough oxygen. And we have hemorrhagic stroke, that one you have Hessian bleeding. I don't know how to put it in. I missed the English with the Netherlands, forgive me. Yeah, Hessian bleeding like cranial brain hemorrhage. Please help me because I'm using the dark with the English. So let's ask ourselves, when you take overdose of aspirin, what will happen to your brain? You get bleeding in your brain. So self-medication and drug abuse has been our problem in the community. Someone will be sick, and the person will say, of course, I have medication, I have medicine here. My doctor gave it to me. Can you try it? But you've not asked yourself, what is the medical history of the person? What is his or her weight? You have not asked yourself. And we did another research that when you take too much of paracetamol, it can damage your liver. So the best thing that you can do is when you have severe headache or mild headache, just take water, go to bed, relax for about 2 hours, 3 hours, it will be okay. And let me talk about aspirin. Aspirin is a very powerful medication, very powerful medication. It's the first medication that they discovered. I think the first medication, aspirin, the first medication discovered. But what I want to tell you is, just be careful with aspirin. It can spoil your gastrointestinal system, that is from your throat to your duodenum, that is small intestine. And it can also damage your brain, it can damage your nerves, it can damage so many things. You get the cranial bleeding that I was talking about. So self-medication is not good. Another one that I want to talk about is the enema that they use. Some they will just from the back. Yeah. One thing is, listen to very carefully, especially the men. There's something we call prostate. The prostate is situated between your anus and your testis or your penis. So whenever anything touches your anus, it has a connection with your prostate. It will trigger the prostate, so that it will trigger the prostate and your penis will be active. Listen, a man will say, I will take a ginger, or I will take the enema, the medication, or something like that, and pass it and just apply it, so that will be more powerful. Listen, there is no medication in it. One thing is, the ginger itself gives pricks, it triggers sensations. Yeah, it triggers the prostate. And And whenever the process is triggered, your penis will be activated. But one disadvantage about it is when you apply the ginger or the liquid, the enema that I'm talking about, it will go into the large and the small intestine, and there are some enzymes over there that protects your large and the small intestine. Those enzymes contain some kind of let me say in our language we say bacteria, so we call it flora. That flora protects your body. So take it this way: when you apply the enema will go inside and wash away all the enzymes out. So whenever you take medication, you know why? Because every medication works from here. You understand? So when you wash away the enzymes, one, you are easily to die because there's no way that your body will be able to function well. Number two, when you go to hospital and doctor gives you medication, to know why, because you've damaged the large and the small intestine. So please, when you go, try to advise your brothers and sisters and your family members that enema, I don't know how to put it, the enema I'm talking about, it's the right way, right? The enema.
Well, that's what how they say, but I think the enema is slightly a little bit, but I think Ghana and people understand it when you use the, what's the word, what's the name again?
But I think it's the right way, the enema is the right way.
Yes, the enema is more or less, sort of similar.
Yes. Okay, let me say suppository. Okay,
suppository.
Yeah, suppository. Let me say it that way. So try to be careful because I know someone who uses I don't say it here, but just try to advise your people. Yeah, here in Europe they use it, especially the men. They use it just for them to be more powerful. You are trying to destroy your system. That is very true. It's very true. And when someone was doing the presentation, he showed something here. It's Coca-Cola in some stores with sugar in. We did a research that when your life or the age that God gave you is divided into three, sugar or glucose or energy takes 1/3 of it, your life. So when you are given about 60 years divided by 3, that is what? 20. You'll be 40 years when you take in too much sugar.
But when do you know it's too much?
When we know very well. One thing that we've discovered is sugar, glucose is poisonous, but you cannot live without it. So what I will advise you is, one, the type that you will take it in. Like somebody will take yam. You know yam contains too much of carbohydrates. The sugar content in yam is too much. So I will advise you to take it around maybe 4 o'clock or 3 o'clock so that you do some activity to burn the sugar. But Ghanaians, we are used to, when I'm done with the food, I'll go to bed. You see, when you are working with these wives, they will always come to work with their food. When they are done around 4 or 3, when they go, they will not eat anything, only small bread or brown bread or something, then they will go to bed. But ours, you take the fufu or you take the yam or the rice, 2 minutes, 3 minutes, the person will just go to bed and sleep. And the sugar content will be in you, and one day you just go away. And listen, diabetes is not a disease, it's not a sick, but it will rather give you something that's more dangerous. Diabetes. When you have too much of sugar content in you, it is not a disease. When you hold it under control, that's why you don't have to stop your medication when you are diabetic. But if you don't take it, it will destroy your renal system, that is your kidney, and there are so many things in your body, it will destroy it. And another one is hypertension is not a disease, but it will rather give you stroke, like doctor said, it will give you stroke and it will destroy your renal system too. So when you are hypertensive, just take your medication. But Ghanaians, as soon as the person is being diagnosed with hypertension, oh, I'm a sick lax. You understand? But most of us is sitting here, when we did a research, and when you take 4 people, 1 of them will be hypertensive or diabetic. But we want to deceive ourselves in such a way that, oh, I am okay. But you are working with hypertension or diabetes. Let me give you one example. In America, when you bring someone to hospital, when you take someone to hospital, when we are done with the person, you yourself, we will check your blood pressure for you. Yeah, it's true. Especially when you are from this country, Africa, Nigeria, Ghana, we will check it for, because It is in our bloodline, whether you like it or not. It is in our blood. Like when my father is having diabetes or hypertension, I have to be careful because it's about 90% that I will also be diagnosed one day with hypertension or diabetes. Okay, I'm switching the subject. Sorry. Let me come back to the medication. You understand? And another one that I want to tell you is try not to take someone's medicine, because there are some medication, anti-hypertensive that I'm talking about, the hypertensive medication. There are some of them works for Africans, others works for whites. We have some of them, I don't want to mention, but I'm going to mention the groups. We have ACE inhibitors, diuretics, and we have beta blockers and channel blockers. Those things, the doctor knows which one is good for you. So when you are prescribed, when the prescription is given to you, just use it. Don't use someone's medication. Imagine I prescribe medication that is meant for a black. Then one day you give it to a white. It will rather give the person a problem.
But if it is meant for my mother and she has the same disease, why can't I use it?
Thank you for the question. One thing about doctors is, as soon as you enter into my office, the first thing there's something that we call spontaneous diagnosis. Spontaneous diagnosis. As soon as you enter into my office, I will know what to do to you before I prescribe medication or before I conduct a little family I conduct a medication examination on you. You understand? So when you enter into my, like you for instance, I don't know your mom. Yeah, I don't know your mom, but I don't know whether you are heavier or your man is heavier than you. So I will just look at you and within 2 seconds I will calculate the BMI. Then I will know the medication that I'll prescribe for you. So imagine you give the medication to your mother whose BMI is even 29 or 28 and yours is about 23. What will happen to your mom? The medication will not work because its body mass index is heavier than you. She is more denser than you. You understand? Maybe it is true that you guys are Africans, but your BMI is different from your mom's BMI. And one thing is, let me say diabetes. We have 2 types of diabetes. We have type 1 and type 2. Type 1 is someone whose pancreas, there's something we call pancreas, it doesn't produce insulin at all. And type 2 is someone whose pancreas produces insulin, but it's not strong enough to burn the sugar. So let's say you are suffering from type 1, and I give you medication. The type 2 people, they don't use injection, they use only medication. I give medication. And your mom is having diabetes. You've heard it, that my mom is suffering from diabetes. But you don't know the type of diabetes your mom is suffering from. Maybe hers is what? Type 1. And you give the medication to your mom. What will happen to the pancreas in the blood?
Fatal, okay.
Yeah.
Does it mean you already have, in your drawers, you have medicine for the black Africans and those for the whites?
I just gave you an example. We have
Discrimination.
Yeah.
I think it's a very important point that you make. It's also, I think, you don't want a situation whereby you go home with a different message.
Very well.
I think what he's saying is that some of the medications are more effective. Not that we can give it to the black people. You know that, for instance, if you are black, the calcium channel blockers is much more effective compared to if you give you something like exactly. So some of them, of course, the black and the white can use it, but some of them you will have much more advantage in it. So it doesn't mean that there is a specific medication specifically done for this and that. And it's also the same. Also, you can apply it. Some older people, some medication are much more effective compared to the younger people. So I think the point he's making is very, very important, what you raised also. Because if you don't, and then you give the wrong medication to the wrong people, it can lead to many, many problems. Because some of the medication also based on other, what you call the comorbidities. Some of the, some of the illness, other illness are all taken into account. So if you don't take it, then you think that, okay, this is my mom or that is taking it, you're going to create a lot of problems for your own.
Yeah, like let me give you one example. The expensive drugs, it has its own way of working in our body. Some of them, the diuretics, it just sucks the kind of fox, the water content in your heart down. You understand? So let's take like your mom or your dad is suffering from just hypertension. Maybe the kidney is producing too much of renal, that we call renal and those things. and the person is not suffering from the pulmonary hypertension I'm talking about, and you give the diuretic to the person, it will not work. Because his or her hypertension is different from yours. So all that I want to say is, when your doctor prescribes medicine for you, he knows what he has prescribed for you. Don't switch it to different medication, because he is a professional. Like someone who is giving paracetamol, the person who take the paracetamol with Coca-Cola or like, you form different chemical compound. Paracetamol is made up of so many things. And when you take it in with Coca-Cola, with sugar in, and cola itself in, it will form, some people take medication, paracetamol with, some people they will tell you, oh, I cannot take medication with just water. It will form different compounds together. Let me tell you something. It's only water. When I open Coca-Cola here or any drink here, whenever it is introduced into the atmosphere, it forms different compounds altogether, but you can't see it. So imagine you take in paracetamol with Coca-Cola, what will happen to your body? So that what I want to say here, I have so many things to tell you, but I only try to tackle the paracetamol, the aspirin, and then the antihypertensiva and the enema, because yeah.
Can I add this one thing is also very, very important, which I think probably you discussed it, but I think it needs to be mentioned.
Yeah.
And that has to deal with, our own, what's the word I'm using for the herbal medicine.
Yeah.
This is very, very, very important
Yeah.
you have to make, because I think that some of the work that we are doing, there's so many people take herbal medicine. We are not saying don't take herbal medicine, but make sure that you don't substitute your prescribed medication with those herbal medicine. Because we know that actually some of the herbal medicine it also have a lot of toxic effects, especially for your kidneys. So please, those that are on prescribed medications, don't use. That many people actually, some of the work you publish, go to Ghana, for instance. As soon as they get to Ghana, they think that their hypertension is gone. They leave it, and by the time they come to the country, they are in the brink of dying because it's going up so much. Or they take this as a substitute. So please, under no circumstances, you should substitute a herbal medicine with what the doctor has prescribed.
Yeah, let me add this before you come. Let me add this. Then ask me. I want to ask you a question because there are so many things in my head. But let me add this one. Wait, I will just listen. There are so many things in my head. I'm not going to damage someone's product or market. I will not mention it. But when you are taking the herbal medicine, be careful, because some of them, the content, they don't know how to, measure them. You understand? They are not bad, but the measurement, they don't know how to do it. Just be careful. And when you take in herbal medicine, that feels like you've taken in ginger or some mint. Be careful, because I'm just giving you an example. Those African medications that they prepare, it doesn't, the preservatives that they use, they want to preserve it for a very long time, so they use something that we call formalin. Formalin is something that we use to preserve dead body. Dead body, we call it cadaver. It's very powerful because they want to preserve it. But all that I want to tell you, I don't want to say so many, there are so many things in my, I don't want to say it. But when you are taking those things, just be careful. Because imagine you taking formalin into your body. Imagine something that we use to preserve dead body. You take it in. What will happen to you? Yeah. And another one that I want to tell you is when you make a fix. I always say when you make a fix, the fix that you make is the size of your heart. So imagine you taking medication, something that will help you build your body. You cannot build your heart. So imagine you've taken Deu Matis or Deu, the Chiboles, small one, the engine into the Mack, the big trucks. The car will not be able to perform because the engine cannot operate the car. The same thing happens to your body. When you take in medication that will build your body, your heart will not be able to pump enough blood or the zoo stop, the oxygen to operate your body. So those of us who are using medication to build or to lose weight, it's not good. Our professor told us the best medication that you ever have is to exercise your body. The heart is made, according to science, it's not God, according to science. I have to mention it, I have to tell it God. The heart is made for 40 years. Human being, after 40 years, anything that you receive is from Jehovah God. Trust me. Yeah, the heart is made for 40 years. After 40 years, that's why after 40 years you begin to feel some unease. Yeah, I feel pain, it's normal. But the heart, the brain is made for 100 years. 100 years. That's why as a human being, I'm going into the anatomy, just forgive me. Human being, your heart can stop. Your heart can stop. But your brain will be functioning. But it will not be functioning for a long time. And your body, you will still be alive. Because it's the brain that controls your body. It's not your heart that controls your body. You understand? So the heart is made for 40 years and the brain is made for 100 years. So any medication that you are taking, be careful because it can go into your bloodstream and spoil your vessels in the veins, like Dr. arteriosclerosis. Arteriosclerosis is when your blood vessel stops, something blocks it, like cholesterol blocks it, and the blood will not be able to flow, and your brain will be panting for oxygen, and one day you just have stroke. You not have stroke, but you have something that we call TIA, transient ischemic attack. You see someone, the man will be like this, the person will be able to talk, but the person will be walking like this. Within 5 years or 2 years, the person will get stroke. So you have to be careful. And one last thing that I want to add is, don't be offended. I'm here to help the community. Don't be offended. Anyone who is using a cream to tune the skin, be careful. Yeah, you can use a medication that will give you a very nice color. That is okay. That is okay. I don't want to mention it. Don't mention it. It's okay. Yes, it's true, but I don't want to offend anyone. You understand? But if you're using any medication that tunes your body, be careful because there's something that in our body called melanocytin. It is in your body that makes you a black person. The whites, they have a very small amount of it in their body. That makes you unique who you are. That makes you black. But when you take in that cream, it destroys the melanocytin. And when that thing is destroyed, what will happen to your body? Your body will be exposed to the sunlight. And when it's exposed to the sunlight, you get something we call actinic keratosis. It's another form of, it's the first stage, or you are heading towards to skin cancer. You understand? So, yeah, so when you are using those, just be careful. You can use any medication that can thin your body, it's very nice, but I don't want to mention the chemicals that they use because I'm not here to spoil someone's market. But just be careful with the medication, with the cream that you use. There are so many things to tell you, but the time will not permit us. So, and there are so many things here. So, just leave me for a while. If you have any question, I'm sitting here. Just ask me, and I'll just.
No, we'll make an appointment.
Thank you.
I think this is what they call complete expose. Some of us may be walking home with very new things we'll be exposed to, and I don't know those who are not here when they will have the opportunity to actually get first-hand information this way as we get it, and it's for free. It's unfortunate we have this situation, some of us, but of course I think I got information there is another program which is also looking at the same subject of health, and of course we have only one community, so it's split, and probably is why some of us are not here. They may be there, but as for health, you've been told your heart is made for 40 years. So after 40, every day you see the light of the day, you thank God. You don't need to go to church to thank, but wake up and thank your God you are above 40 and your heart is still
Now we
functioning.
shall go to the churches.
Yes. I think the original concept we had at the workshop level was to split the group into two. But the number we have here, I don't know if we can still do that, because we were going to then go into the discussion, level of the whole system and be able to what we will call rationalize the issues that have been put forward here, and then find a way to make suggestions, share ideas how we can deal with some of these challenges. But by the time Mr. Reno Sachiampon will finish, probably we do a very quick thinking whether the group can stay this way, and then the presenters, we will find a way to go through the same workshop process, but in the general format, so that we see how maybe we can take the questions, come up with ideas, and then we make some notes, because we must have some proposals in terms of solutions to some of the challenges that are coming up here. And please feel free, you should be able to share your personal experiences. I don't think we get this time with our doctors in the consulting rooms. The time is very short. When you are there, somebody is already in the queue. And the doctor, I'm sorry,
let me add this.
Yes, okay.
Sorry, let me add this. Very vital information. Just let me add this. Like doctor said something here. No, my sister said something here, that language barrier. Yeah. One thing is, let me say this in Tree.
Okay.
Like someone will go to hospital. In Ghana, you say in Tree, you say Limuya Meya. Okay. How would you be able to go to present to your doctor that Limuya Meya? The English language you don't know. It's Limuya Meya in English you don't know. Sorry to add that one. Limuya Meya, you don't know Limuya Meya in the official language of what? Ghana, English. That itself is not working at all. You understand? So how do you be able to go to your doctor and tell your doctor the Muya in that or in G? So I was telling some people there are so many ways you can present your case to your doctor. Here in Netherlands, we have so many types of pain. When you go to your doctor and you tell your doctor, I have a pain in my head. What kind of pain do you have? You're gonna tell your doctor, I have pain. Like somebody is cutting. You understand? These are the things. That's why they always say that doctors are not good. You understand? It's the way you present your case. You understand? So I was teaching some people, we have sliding the pine, bunking the pine, and trekking the pine. There are so many pains. So when the person tells me that the person is having bunking the pine, then I know, oh, okay, the person is having a migraine. You understand? These are the things that we have to teach the community. That I have this kind of way. So imagine a program is conducted. Just a program is conducted to train people and also to train others how to present your case before a doctor. Oh, I have a pain. I have pain in my stomach. It's a pain in my body. The doctor will ask you, can you describe the pain? Oh, the pain is bunking the pain. Okay. What's the pain? Then you show the pain. So that the pain happens now too. Pain, no, that the pain goes anywhere. Then the doctor will say, oh, the person is suffering from this kind of problem. You see, that's why we are dying rampantly. The doctors are good. Somebody will just meet me at RMC and tell me, doctor, I feel that just too much. No, doctor won't stop someone blood. What am I going to use the blood for?
Thank you very much. I mean, we heard him say we have to educate the community. I think the first person to help you is you yourself, because we live in a country that you have to chase the information. Nobody is going to bring you the information. And the unfortunate thing, I don't know how long you've been here, but I think we don't have our priorities right. That's the problem.
3 years.
For 3 years. Okay, you're welcome. Take time to know the community, because if you organize funeral here now, this space will not be enough. I think we know it, and it's the misfortune we suffer here. This issue of these results from the research, we've found a way to talk about it. Even they will bail me out to get people to come for the physical examination. It's like begging them, and it's all for free. Some will go there only to be told they've been working for years with hypertension. They didn't even know. So you can imagine this kind of thing. So I think as for the job, you have a lot to do. Some of us are tired. So if you are new, then you have so much to take out from here. I think we will quickly allow Mr. Achiampong to share some information about what they are doing in Ghana, trying to work in with some institutions here to carry much of the standards back in Ghana. So, Mr. Achiampong,
thank you. For those who don't know, my name is Ray Champon. I normally don't speak on health forums because it's totally not my field.
Yeah, that's true.
But I'm fortunate to be able to do this, what I'm trying to do. I'm an accountant by profession. So what you are doing, I know a couple of years ago, the Minister of Economics, Saraka, the registered accountants and those people were trying to educate foreigners to become accountants. Why? Because of the, not per se the language barrier, but the understanding barrier. You see, the fact that we both speak English, or we both speak Dutch, or we speak Twi, doesn't mean I understand you. So we as a community, we really need to think and source ourselves. Do we really need doctors? Yes, we need doctors. We need you. You see, when I say, Mimuya Miya, you know where I'm coming from.
Yeah.
You know I'm a Ghanaian, you know, okay, you know the type of question you can ask me for me to be able to come out and explain myself to you. You get me? So we really need to put our hands together and tell our young ones and motivate them. You can do it, you can do it, you can do it. So that is just a part of thing, just because of where I'm coming from, because of why the ministry wanted to have more accountants, because many of us were going bankrupt. Why? Because we are not paying our taxes, we are not doing this, we are not doing that. So that is just a side information for us here. We started back in 2002. I went to Ghana and I saw the healthcare, how it was going there. And with the little knowledge I have about healthcare, I knew one day I'll become 40. And God willing, I'm 40 now. So my heart is still not strong. I knew when I get to Ghana, I will try to eat well, I will try to sport well, but aging brings a lot of things together. And I might need help. And I saw how the health system was going on. I went to Konfonochi. My aunt was there and she got stroke. They needed to do some lab tests on her and other things. And it was supposed to be taken to South Africa. The results was supposed to come back in a month's time. So that was in 2002. So I looked into my brother's eye and said, hey, what are we doing here? We were not born here, but we are studying here. You are a lab technician and I'm an accountant. I don't want to hear this anymore. I need to be part of the country whereby we can bring a level up and help the community. So we started. We took a step. And a couple of years later, we have a 3-story building in Kumasi. Unfortunately, Rodam, as you said, we are part of the project.
Okay.
We just did some of your samples went to our lab.
Okay.
Which we run for them, so I know Rodam. I send them invoice, so I know them. So we have a 3-story building in Kumasi. We are the only medical laboratory today who's running 24/7. Now, as I know, KCCR, which is Rodam, they are doing researches. And there are certain labs that they don't run. They don't run for private. Like molecular biology, they don't run. I'm saying this, if I'm mistaken, don't hold me onto it, it's not my field. We will be the only one in the whole West Africa, not even in Nigeria, do they have molecular biology. We will be doing them. We will be doing the HIV virus, we will be doing the hepatitis B, we will be doing everything. It's just information that we want to say. We just want everybody to be part. And I really appreciate being here this evening. I wanted to be here from first minute. There is a lot that we can, but I am really shocked to hear our Ghanaian programs here. I was actually coming here to say, people, we have so much. Let's join our hands together and go help our brothers back home. But now I don't know what to go back and say. I'm really shocked because this information is new to me. It's really new to me, but it's also good to me. Because I shared information back and forth. We are giving information, and I hope after that, after you guys are done, I will get your phone numbers, and I will bring you the information which is there, and you will bring me information which you have here. What I'm saying is, even though we are not as healthy as we are today, I believe there's a lot of changes that we can do in Ghana, which Ray-Ban Diagnostics is trying to do. What we say is, Normally, sometimes when your family members are sick, as Uncle is saying, the stress, you get a phone calls and they will tell you, grandma is really lying sick down somewhere. And you'll be like, but Uncle Akwesi is there. But if I bring that money to Uncle Akwesi, you won't use the money for what is the main purpose. What we are trying to do is make sure that at least we are from Amsterdam, we are from Holland. So we know, you know as you know, what we are trying to do is, we are trying to learn to know all the qualities of each hospital, or the clinics. I mean, if you are sick, if you have a headache or you have anything, you go to one hospital, they will tell you, I can do everything. It's not true. What the information we have, we know who is best in which area, at least now in Kumasi. Which hospital is very good. So if you give us a phone call, like my granny is sick, is here and there, can you guys assist us to help? We are there always to assist you. One thing that we always do is we also go to houses, like here, we have our motorbikes, we ride like 1 hour to go and take medical sample. We do everything, but especially because we are from Holland, because we say we were born in Ghana, you see, bred in Holland and going back to Ghana to help the community. And we really want to, now we think it's time for us to tell the Amsterdam and the Dutch community, remain diagnosis is here. Whatever you are used to here in Holland, like when you go to the AMC to take a blood sample, the way you are received, the way your information is kept, everything. I would like to invite you all one day to come and visit us and receive what we can offer. But if after that, if anybody wants any information, I have so many information going on. The herbal medicine, my brother, I have so much information for you. You see, because it's not my field, it's always fascinating to me to see what is going on. Somebody might have fibroid. Yeah, for you to be able to, I look at my brother, he's a medical guy, and I sit down and say, oh, I want to say, Misuma. You see, the way, the hard work he needs to do to convince people that for so many years, people have been lying to you. You see, somebody who with the herbal medicine will tell somebody with the fibroid, if you drink it, it will burn your fibroid. Now, how do you explain this to somebody with more than 5 years of this experience? To tell them all this information is not true. So what we do, we take the time, we go to Google, we open it and we show you, it shows them that is fibroid. Show them the body, that is where it is. And when you bring this herbal medicine, this is where it passes through. and unfortunately it works, but the question is how many people in Ghana has this time? And that is the culture that we are trying to break. And once again, it's unfortunate to hear that here we are still having that, it's a cultural problem. You see, self-medication after car accidents, road accidents in Ghana, self-medication is one of the biggest causes of death in Ghana. Self-medication. I'm not a medical guy, but I know that taking antibiotics every time with TME, you see, one biggest problem is malaria. You see, malaria is so big that everybody in Ghana, I have malaria. Go to drugstore and buy antibiotics to cure it. And that is happening here. That is why we are doing it. So you will be sick here. That is what I think that's information I need to give you. And you call your auntie in Ghana or your mommy. Oh, maybe I'll bring you this herbal medicine. You see, it's not a problem here. Only it is what we are used to. You see, I will give my own wife as an example. I came back after 6 months in Ghana, and she has lost weight. And I know her friends are saying, why do you still go on jogging while you are so tiny? And they really believe me. It's a young girl of 23 years, she's 120 kilos. She's the one telling the one who's healthy, why are you going jogging? You see, our perception needs to change. Our perception of sorry for my words, big boobs, big butts needs to change. Your heart is important. I'm not a medical person, but I know whenever I'm feeling tired, I know something is going wrong in my body. I need to stand up, wake up, and go jogging. This morning, I woke up, I was saying, this is a time I need to wake, I need to do something. We need to take our health very important. Very, very important. It doesn't take a lot. I know we are poor, as they say. It's really shocking again. I'm living in Amsterdam. I'm raised up in, I just learned this results that the Ghanaian youth are poor.
Yeah.
I just came back and learned of it. How can we be poor? Can somebody give me one reason why we are poor? I get the same opportunity as the white guy sitting next door. There's no way you can refuse me of getting a job. I mean, you can't refuse me in this country. So why are we poor? You see, it's quite unfortunate this room is not filled up. We also need, I think it is more now, we need to go to the churches again. We need to let them open our doors for us because we need to share this information. The people sitting here is true. We will come to Ghana, you will see us going to churches every Sunday.
Yeah.
We are breaking the doors down. Because their perception, the lifestyle must change. And I told them, if you are working for Rebel Diagnosis, you have a problem. And they will tell you, we haven't been to Holland before, but we are looking at it. We need to work, we need to change ourselves. You see, because my strength, I am as strong as you are. If one of us is weak, as Uncle was saying, if it was a funeral, we all attend. And if the one that doesn't attend, you are not my family member anymore. That is the same thing as in Ghana as well. So health, that is why I've stopped being an accountant. I'm going back to basic and start life again. This is very important. So we are here as Rebel Diagnosis. That is why I'm standing here. I didn't thought I would be standing speaking. I would speak more than 10 minutes to help those in the field. We can only be a mouthpiece. And we are working in partnership with the AMC, Professor Stork.
Okay.
He's a partner. We're also working with Erasmus, the field. So if you go anywhere, you mention Rebel Diagnosis. Every test results that goes out in Ghana is based on the standard that you are using here in Holland. So that is what we are trying to do. So it's, in a nutshell, that's what we
I just say one thing.
Please.
A very interesting story. One of the famous professor in New York told me, he's a good friend of mine. And he's a Nigerian, he's very, very high up. And then he said that he was doing a study in Nigeria, one village. And of course, someone from New York went to this village. The lady, she wakes up in the morning and she starts jogging. And so the little village, everybody, this person is coming every morning. This lady keep on jogging. And then one morning, one man just stood up and they said to her, he looked at her, he said, "Lady, who's chasing you in this village?" I think that's purely, summarizes what he said. Because the perception, as we said, so the perception itself is so deep into the community that we need to really, really work hard to change those perceptions. Until we are able to do that, what we're going to do is just going to be very, very hard. So the perception part, I think, is so crucial.
This is just for those people who couldn't make it or who did not come. According to World Health Organization, every human being have to exercise not less than 1 hour a day. Exercise your body or do something, any activity, not less than 1 hour a day, and you will live long. And just advice to any healthcare practitioner that we have to give it to our patients. So for those who couldn't make it and those who did not come here, this information for you. Yeah.
We are still going to source more of the way we can deal with some of these problems. They are very inherent, they say. But of course, thank God, if you can stand on your feet. I think somewhere, was it this morning or yesterday, I was reading somewhere, they say, well, if you cannot stand on your one leg, you are prone to anemia. Yes, you are easily on your way to getting that. If we could walk here, then at least those of us here, for the sake of those who are not here, let's brainstorm and see what advice, I will call it, we can have first for ourselves by way of what we share here, and then those who are unable to be here. I hope those who are not here are at the other place, because of course I don't know what's going on there, but health is one issue you can always talk about. So let's hope they will. Now, the concept I mentioned earlier we had was, after the presentation, we were going to split ourselves into 2 groups, and one group will look at specific